slide. I want to sort of firstly say thank you so much for joining this breakout group to talk about technology and trust. And I have framed this conversation. I sort of took license and privilege based off of our conversations to ask this very broad question about what makes for a trustworthy relationship, okay? Particularly in a clinical setting, and most particularly between you and your provider, right? So Kim, if you could bring that slide up, and we'll talk a little bit about, you know, what we're going to think about and what we're going to do. I know broadly we're thinking about trust and technology, but I think we first have to level set, you know, what does trust mean? So I'm going to offer you this definition that I've abridged from something, you know, as any academic would. Of course, I turn to the literature to ask the question, what does the literature say about this? Man, they gave a super convoluted, you know, discussion that I had to diagram and figure out trustor, trustee, like who were they pointing to? And then once I figured it out, I was like, oh, this is what you mean. So I offer you this idea that trust is the belief that I, each of you, us as individuals hold. Okay, it's mine to give or not. I either trust you or I don't, so I'm the giver of it. Is a belief that I hold that a physician will act in my best interest, even if that action, even if that thing that I'm requesting of you, my dear physician, may not be in your own best interest. So let me let that set for a second or two. And then I want to sort of, you know, if you can give me like a little thumbs up, you know, using the reaction key or a little something in the chat. Does that work for you for right now as a baseline concept of trust? You know, yes, no. Okay. I see some people still contemplating. Those of you who are off camera, if you could use your reaction key and let me know, or just come off and say yes or no or maybe. So the question is, what is this best interest thing? So think about when we're talking about it may not be in the physician's own best interest. There are lots of constraints that clinicians experience in their practice of care. Constraints that create a kind of moral distress. They know what the right answer is. This is what's best for my patient. But the system, the insurance, the amount of time, these structural barriers are getting in the way. I can't keep you any longer than 4 days. Your diagnosis says you've got to leave on the 5th day. I can't keep you unless you want to pay $3,000 a day, right? Or, you know, these are some of the things that I couldn't do because it's not in my best interest to do that. I would get dinged. I can't order all of these, you know, tests. I can't oblige that. I could potentially lose my license. So those are a range of things that could not be in a clinician's best interest. And I offer that as some examples. The physician or the institution, because they are a representative of the institution as well. There are those structural constraints. Sometimes they may not know why, right? Do I have any clinicians in this room? You know, not to out you or anything, but pretend that I had some clinicians in this room. I'm pretty sure they don't know what my insurance is, okay? I'm pretty sure that they don't know, am I covered for this particular medication? Or is the copay going to be $25,000? Or do I have to hit, you know, a $5,000 deductible before the insurance kicks in? They don't know that, right? So there's a lot of constraints that happen. I have lots of things to say. I'm going to say one more thing and then sort of tack back to what's on the board here. I am a faculty member in the medical school in the Department of Population Health at Dell Medical. And there's something that we are trying to do differently. You see my sign, I keep this sign on the back, we are rethinking everything. Some days that's not so hot as others, but it's a good mantra because sometimes I just catch up and they're like, no, we've changed again. So there's medicine is a very transactional based practice, and the transactions are how we get paid, right? So the more things one can write up within reason, the more transaction, the more money. It's not necessarily tied to outcomes as an overall process, because that's the system in which we live. We have to generate money to pay the bills, to keep the lights on, to keep going forward. And those payments come through the generation of transactions, okay? Be they surgeries, be they CAT scans, MRIs, blood draws, you name it, it's a transaction. At Del Med, we're doing something called value-based care that really flips this paradigm on its head. And it takes a more holistic approach where you do have a treatment team that comes together when you come to the clinics, right? Where you have, if you're going to see about X particular part of the body, the team also has a social worker, okay? It has somebody from physical therapy. There are a range of people that are a part of this immediate team, okay, to better serve and respond to your needs. And we look at the return. We're always asking. I had tore up my knee a couple years ago while I was first here at DMS. And I remember it was very interesting. I came in and the physician said to me, you're reporting a lot more pain than you were the last time you were here. And I was like, somebody's been paying attention to what I said, but because we have changed the model of the way that we respond to care, not as transaction, but by putting the patient in the center. It's a very different and somewhat novel approach, but I think it could be the key to how we disrupt how medicine has been traditionally done. I don't want to worry more about that because it takes us away from our conversation today in part, but it does still raise this question about what is trust in trustworthiness. So let me sort of bend this next question that I want you to ask to think about it this way. If we're thinking about trust and technology, and I happen to have these books, not because I pulled them for today's conversation, but it was last night's meeting that I was in. I ran to my cabinet and I was like, yeah, you want speakers? This is who you need, okay? This is a book called Weapons of Mass Destruction. It's about issues in technology, automating inequality, the new Jim Crow, Ruha Benjamin, race after technology, and last but not least, algorithms of oppression. Just light reading. That's on my bookshelf. But it raises a lot of questions about what is this trust thing and technology? And so let's bend this into trust and technology in healthcare with your physician, okay? And when we sort of mash up these ideas, I'd like to ask you to engage in a bit of a thought experiment. I must confess, I do have a master's in philosophy, so I do a lot of thinking. So I want you to join with me for a moment in this thought question about, and answer this question. I trust my physician because they are thoughtful. They are what? Okay. Answer that question. And if you could put your responses in the chat, we're going to start grabbing them and put them out here and begin to have a little conversation about what is this idea of trust? What am I looking for in this setting when I say I trust my physician because they are? So we're building out our little dimensions here of what you're saying. And if anyone would like to come off mic and just sort of, you know, start a conversation, please, I encourage you to do that. This group is small enough that you can, if you want to go into, okay, wait a minute, where's my commands here? If you want to go into reactions in the little smiley face that says reactions, there's also, when you pop it open, there's a little thing that says raised hand. If you want to use that, that's fine too.
Virginia, I'll jump in.
Thank you. Introduce yourself, please. Just your name,
hi.
you know.
Hi, my name is Srini. I'm based out of California, and I run a startup here. To me, like when I think about trust of physician, I feel like, you know, if the physician's working together with kind of a number of other sort of professionals in the field, right? So it could be a nurse practitioner, it could be a social worker, it could be a dietitian, it could be physical therapy. When I come across a physician where it feels like that person is working as part of a bigger team, I feel like I place more trust in that, as opposed to somebody who is working silo, right? So somebody who feels like they're not above everything else, who's just not going to dictate their terms, the medication, the prescription, and then just walk away, right? So I think a physician who works as part of a team is somebody that I'll say I place trust in. And then just stepping back, if you think about in our daily lives, beyond being a patient, who do we trust the most, right? It's our families, right? Because families work as a unit. Again, they're all kind of bouncing ideas off each other. You know, it could be the mom, the parent, the dad, the siblings, and so on. So I think when you come across a physician who's kind of emulating that idea of what a family does, right? Who's bouncing ideas of other people in the healthcare system, my trust level immediately goes up. So just wanted to share that.
If I could sum it up in one word, that groupness creates a kind of accountability it's sort of, you know, the nefarious side of my mind is like less likely to have bad things happen when multiple people, you know, are in the room bouncing ideas off. Like I might go down a rabbit hole and my team's like, but is that really the point of what we're trying to do? And I'm like, oh yeah, you're right. So we're more accountable to one another. And,
yep. Yeah, it's the idea, you know, that, you know, two brains are better than one, right?
Gotcha. Okay. Kim, how are we doing with all the things in the chat? And we'll enlarge this in a minute so you can see what we've said.
I think I've gotten most of them. Can you see my screen okay?
Yeah, can you enlarge it? Yeah, and then push, yeah, couple more clicks. One more time. Cool, and just push it up. Yeah, how does that look to everybody? Cool, all right. So I'm gonna, good listeners, honest and knowledgeable, trained to do the right thing, open, honest, receptive to my questions, professional, experienced, truthful, on my side, because he or she hears my needs, knows what, responds to what is important to me, competent, transparent, authentic, empathetic, vulnerable, has a strong medical training. So how do you know those things? Okay, so I want to offer you this quick observation. You may have heard this. It's an old quasi weird joke. Way back in the early 60s, when Justice Stewart was on the bench and they were looking at this obscenity clause and trying to figure out, you know, what is the community standard of obscene and profanity? His response was, I'll know it when I see it. Okay. So is trust something that we know when we see it, or can we do something, can we say something more about explicating it, uncovering it, unearthing it? How can we think about what would be the good housekeeping seal of approval, you know, in this space, that we could trust it? How can could we recreate, how could we create that? Or what it's more than I know it when I see it. That's my challenge to you.
Virginia, I'm sorry, are we taking questions? Is it
Oh
okay
yeah,
that I
yeah,
jump
this
in?
is a
Oh, okay.
conversation.
Okay, great. I'm Julia Forth. I'm with Cancer Support Community Los Angeles. Nice to meet you all.
Thank you.
It's interesting in this situation because trust can, it seems to me, equals time. You know, you need time to trust someone. So in a doctor-client situation, you have to do your due diligence prior meeting that person. And we have group support for cancer patients, and in those groups they talk all the time about who the physicians are that they trust in Los Angeles. You know, so there's a lot of information that's passed along between the people at our community about who they want to go to and who they don't want to go to. And that, I guess, is part of that time element I'm talking about. It's hard to just be discreet about trust and say, yeah, I trust this person right now and I've never met them. You know, so it's a difficult, I think, thing for patients and practitioners. You have to build trust, I guess. It's a very short way of saying what I just said. You have to build trust, and that takes time sometimes.
If let's flip that observation, Julia. Is there a way so let's flip the question this way. So we've sort of answered it from our own experience, right? Like I would trust my physician if, right? So let's reframe that and say, I'm a physician. We are physicians. We are healthcare providers along that continuum, okay, in our center, and we come together as that team. We want to demonstrate to consumers of care that we are trustworthy, that you can trust us. Given what we've said as consumers, okay, we're the ones who give that trust, right? I bestow my trust upon you. I choose to trust you. What could I do? What could we do when we flip that paradigm and we ask folks to demonstrate their trustworthiness? What might we, as healthcare providing teams, in whatever way we do it, what might that look like? So is this track record referrals from other patients or care? Okay, so like some kind of index, you know, my patients are saying this about us at the center of XYZ, you know, at Livestrong, our patients say, you know, we're reliable, we're whatever. Is that one way? What other ways? And it's not, I don't want you to, this isn't about selling it. It's really about demonstrating it. If we were to try to take these words that we have here on our board and invert them into actionable items and ask clinical folks and their teams to show this, what might that look like? Meredith?
Yeah, one thought that comes to my mind is the word humility. And I think in humility, first, the reflective listening, taking time to hear the patient so that they do feel like the physician is hearing what their concerns are, and then not just being totally definite in their response or answer, but when uncertain, you know, if the physician has the ability to say, let me get back to you, or let me consult with my colleagues, or and demonstrate that he's part of a group think, that he's not going to be so definite and so confident that he knows the answer above anything else, that he can demonstrate that he is part of that holistic team, and he's getting consultation in case there's things that he maybe hasn't thought of before or doesn't know, or someone else's opinion might weigh in and be helpful for that particular patient.
Yeah, I'm just a little factoid here when you talk about not knowing everything. there's just like this stuff I study. I think you'll find it interesting. If you think about the shaping of medicine and developing physicians and schooling of physicians in particular, it got codified in this thing called the Flexner Report in 1910, right? Very basically, it says, medical school is this 4-year experience and it works like X, Y, and Z, 1, 2, and 3. That was 1910. It is 2021. How long is medical school? 4 years. So what we knew in 1910, we didn't even have penicillin. We really, truly didn't understand how to do a lot of things that we understand today, but we're still pushing it into this 4-year frame, and certainly residency programs have different time frames, but that core body of knowledge, of course, no one can know everything, right? And we do have to rely on this larger team. So that idea of humility, and going back to Sunir's earlier observation, of this group, the group taking accountability for one another, right, is a key component of what we can demonstrate. So we're trying to capture some of these in an alternative color to see what we get, from our conversation, and see what we can make sense of. Other ideas, how when we put on, so we answer the question, if I went to my doctor's office and I wanted them to show their trustworthiness, that they were a trusting organization, what would I be looking for? We'd be looking for humility. We'd be looking for, I can't see that, accountability, and we'll make them bigger in a moment. What else might we be looking for?
I think experience is another one, Virginia. So for a given condition, right? I would love to see a physician say, here are three patients that came in with your same condition, and here's how I hit it out of the park, right? They went home within a month and they were completely healed. And by the way, here's another 3 patients that, I treated, and you don't have to disclose the patient, details, but, to speak broadly. Here are 3 patients that maybe, I learned a lot from because their treatment didn't go as planned. And I think the whole point is, again, gaining that trust by showing what they've done well in one place, and maybe what they've learned in another case.
So could I add to that word of experience, transparency, as another feature or virtue that we think is important? Because I'm not always going to be, if we define successful going home either cured or in a cancer scenario in remission, that doesn't always happen, right? So to be transparent about, what we learned in that process. Okay, cool.
Another thought that comes to my mind, and you touched upon it, obviously medicine is continually evolving, and what was defined in 1910 is certainly not what is in practice in 2021. So I don't have exactly one word for it, but it's research. Ideally, the physician is engaged with current best practices and moving the needle forward. So academic excellence, commitment to research, certainly reading the research, attending the conferences. So while my expectation might not be for the physician himself to be conducting the most recent research, certainly being aware of it and in that collaboration, but something around that, the academics and the research component of whatever my particular situation is.
So one of the characteristics, there are broadly 9 tenets of medical, the medical ethics. When you go look at this 9 or 10 statements, one of them is this idea of lifelong learning, right? That we are committed to always, staying engaged. And how do people demonstrate that? I just came back from the latest conference, or, where they were talking about this new treatment. So being able to see and hear that is an important feature, that you're up on the latest evidence-based practices. All right, so these, are these, well, I think there's a hidden question that I want to ask our group to think about, because the theme of our conversation has been centered around equity, right? And so equity, you know, and if it's too much of a primer, forgive me, I just don't know where everybody's, you know, baseline is. But we think of equity differently than equality, right? I can share with the 13 of you my banana nut loaf piece of bread, and I can cut it into equal slices of 13, right? And share with you equally. But that might not be the most equitable distribution. Some of you may be allergic to the nuts that I put in there. Some of you maybe have a gluten intolerance. Some of you may hate bananas, okay? You know, so now I'm gonna have to start dividing differently, you know, my pieces, because people have different needs, right? They have different needs. It's typically this picture, if you've seen it, you know, illustrated, 3 people standing at a fence wanting to look over the fence to see the baseball game. And there are 3 boxes. One person's very tall, one person's very short, and one person is sort of just right in the middle. But if I distribute the boxes equally, right, the shortest person still can't see, the tallest person is about ready to fall over the fence, you know, and the person who can still see. So, you know, redoing that and making it equitable is giving the shortest person to the next one, and the tall guy doesn't need anything. And just for your information, some people do say take down the fence, and I'm like, yo, it's baseball. You need the fence, okay? That's my pet peeve. It's baseball. You need the fence. But the idea is, when we think about addressing the gaps, we heard from our presenter, Jody Ann, who talked about her podcast, Black Cancer, and sort of woven into that was her experience as working on this public health project and coming to differently advantaged communities and what that does. How do we think about this concept of trust when we want to create an equitable lens? Okay, do we bring it in more finely? You know, do we pull it out? What other considerations are important when we think about creating a trusting environment? And I'll let you ponder for a moment or two on that. So I'm gonna be a little more directive here, and feel free to push back against what I'm saying or offer an alternative, but for sake of discussion. When we're reaching out and talking about these kinds of issues, Jody Ann talked about these several different engagement practices, right? When she was rethinking the project that they had done overseas. And she raised things like about motive and substitution, you know, the positionality. Well, if I put myself into that situation, would I tolerate this? You know, would this be acceptable to me? Context, the nature of the problem, tone, equity, building trust, these range of things. In the space that I live in, and you know, academics is all about renaming the same thing and giving it one more variable to call it your own. You know, it just is. I need to be honest about that. We call it broadly in the discipline and the work that I do, community-based participatory research, right? CBPR research comes from a strength-based perspective. It says communities have been living and thriving well before any of us entered into them, okay? We may see this community of folks who are living with cancer, you know, through this, we may have a distorted lens, you know, about what's going on, but folks have been living, doing, and thriving. Who are we to say that this is less than or substandard or not good, right? CVPR says there is a strength-based component to community. Communities, when you ask them, can tell you what they need. So we put community at the center as researchers, right? So as a researcher, if I want to engage in community engaged research, it's not my idea, like I do this mental health stuff. I should not be the creator of the mental health research question. I should be asking my community, what's important that hasn't been addressed as it relates to mental health? And I may frame it within my expertise. I'm an ethicist. I think about issues of autonomy for people living with serious mental illness. How is their autonomy at risk in the middle of a mental health crisis? What's missing from this community? What has been your experience? What could we be doing better, right? Let's identify and lift that up. What's been working well, what's been working not so good. So when we think about this next set of questions and we add sort of an equity frame to this, where might we go? How might we get started? What do we need to better understand? Sort of the who, what, where, why, when, and how of it all. Julia, respect. Can you say a little bit more about that?
I think, and correct me if I'm wrong, you talked about environment, what type of environment, and in asking a community what they need, that sets up a relationship of respect. You know, you're not going in as the person or the entity that knows what that community is. You're going to that community with an open ears, open mind, open heart, and that's a very respectful thing to do. I think, you tell me if I'm on the right track, but that I think is very important, and it's something that we're doing a lot of now, where we're going into the community, we're training people who live in those communities, training therapists who live in those communities to deliver our programs within those communities so that they can feel comfortable and listened to, instead of us being the entity that goes to them and tells them what they need. And I think it's a very respectful way to engage with
right. So it ties back to one of the pink Post-it notes about collaboration with others. So that now we're taking this lens. Our original focus was sort of collaboration within, like, here's my clinical setting, and now the statement is about taking that same collaboration to consumers of care, to stakeholders, family members, persons who are living with this experience, and saying, tell us more, collaborate with us. We often have this running joke that when we go into community, we might have these ideas. Oh, you know, this community needs this to fix that. And you actually find out, if you want to really put a walking program in, that they need speed bumps at this main intersection before you even do that, right? Because that's the current barrier. So that collaboration gives us a chance to do that. When we think about engaging in a more equity-based approach to trust, what other ideas might you have about how we do that? As Julia said, we can go, we're training people to go, who live in the community, to go into the community and talk with community, and sort of, am I correct in saying, you know, rethink, repackage, revise how we do this thing?
Yes, correct. We're even changing some of our language that has been part of our language for 40 years, and re-envisioning the way we deliver our programming in a way that we've never done before, based upon what the community wants. And yeah.
So let me ask you this. Imagine this. In a collaborative space, could we imagine creating, in any role that we're in, okay, whether we're consumers of care, whether we're advocates, whether we're lived experience folks, from whatever perspective you are in, is it possible to create a 10-point plan? I like, even numbers, that says something about, this is our version of the good housekeeping seal of approval. We are an organization who is committed to, and then let's sort of look back at what our stickies are telling us and create a process. Is that how useful might that be? How might we do that?
I'm sorry, can you say it again? Because I think it's an interesting idea.
Well, okay. I'll tell you what, it's something that I'm working on. I have this project, and we've been funded by the Patient-Centered Outcomes Research Institute, PCORI. And we are working, we have a group of collaborators who are community stakeholders who lived experience, our focus is around mental health, lived experience, advocate organizations, academics, we're all one happy group. And we're talking about, we've gone through a journey of understanding, what is research? What are the constraints of research? What does it mean to do equitable and ethical research? And now we're asking the question, if you came into our organization, any one of our partners who are part of our collaborative, if you came into their organization as a researcher of any kind, community researcher, academic researcher, whatever, we're creating a statement that says, if you want to research and collaborate with us, these are the 10 points that you must uphold. We expect X, Y, and Z, 1, 2, and 3 of you, dear researcher, before we're even really going to have a conversation with you about the research that you want to do within our organization, or that you're asking us to help recruit for, or whatever. It's a paradigm shift. It's a real shift about what does it mean to engage with community. And it's not about it's not directly about participants in it. It's about co-creating how you do this. Does that make sense?
Virginia, it does. And tie that into the trust discussion more directly for me, if you could.
Okay, so when we think about trust, so often this conversation is top down. It's highly academic and very removed from the conversation that we're having, right? Like, what do we think in this room trust is? And we've given words. So if you're trying to create if you're trying to create an intervention that's trustworthy, you've got to go to the folks whose trust you're asking for, or whose trust you've breached. So let me step back just a moment with that. When we think about engaging with Black communities in particular, as a Black person, this is very close to my lived experience and part of my research. I will always say that when we talk about trust in the Black community, it is not regaining trust in the Black community for research to continue to be done, to be uplifted. You cannot regain trust where trust has never existed, right? So we've got to step back and ask this question. What does trust do? We can go to the literature like I did, because I'm a good academic. But the problem with the literature is, does it make its way into everyday consumption? It sits behind these paywalls. It's not readily accessible. We can see from our pink and yellow that we don't see this demonstrated on a flow chart or something, or a wall mural in our doctor's office. Okay, there's tons of literature out there. We don't see it manifested. And so when we think about building trust at the community level, right? And you can define community in a range of ways, right? Social, ethnic, racial, which is really all kind of BS, because like those are sort of socially constructed, but that's a whole nother story. you know, people who live with a particular disease, whatever. You can build your communities anyway, but to be in collaboration, to show humility, okay, to enter into those spaces, not knowing what is important to people is the game changer of building that trust, that we're going to build this together. We may have independent goals. It may be like, forgive the analogy, if you will, budget reconciliation. You know, let me go talk with all the players and see if we can get on board and get most of what we all want. But it is that conversation and being engaged with the community members, not as just a focus group. Let's just go ask some folks, right? But as co-creators of knowledge. That's the key linchpin that makes building trust different. Co-creators of that knowledge, that communities are just as knowledgeable about themselves as professionals are in their own particular disciplines. And that if we can come together as co-creators, we have a much stronger foundation of trust to build on. I'm getting this note that says 2 minutes left in this group. Is that correct?
Yes, so we're trying to extend the breakout room. Brittany is trying to do some magic back there.
Oh.
And so if it works, we'll all get to stay. If it doesn't work, that's why we needed to let you know. So if it doesn't work, then we'll all go back to the main room where we're going to together kind of summarize what we've been talking about. So fingers crossed that, that we can get it to work.
You're going to leave us hanging in the middle of this aha that I think we're getting close to.
Virginia, I'd love to just react, I think what you're doing is fascinating. And I just would say in my own experience, no amount of information has ever resulted in a trusting relationship that I've had with someone else. It does require that personal interaction. It does require someone to be genuine and authentic and transparent and vulnerable and empathetic. And I've got to be that in return. It's a mutual thing that happens. And you do know it when you see it, getting back to the justice's words, you know. And I wish there was a way that we could bottle that, you know, but I don't know that we can. So so that trust occurs with my direct participation, but to scale it the way I can come into a new relationship, and if I've got the recommendation of others who I trust that have already been through that process with that moves me way down the pathway of establishing trust with that person or organization. And so so that's a thing I think that Livestrong and others can do, you know, in helping to scale the, you know, building trusting relationships in this space, is by having a network of people that we can come to trust because we're in the same circumstances, you know, and if you trust them, then I go into that situation, you know, with the more open, trusting attitude. Mm-hmm. So at any rate, I'm done with my rant.
Yes, and how? Because we've got to leave in 14 seconds. How do we create an equitable creation of that, right? Because you're absolutely right.